Zero suicide is a healthcare model that's designed to be a care pathway spread across healthcare systems to prevent suicide. Henry Ford is the birthplace of zero suicide, developed in 2001 and implemented after a lot of work with our clinicians, patients, and healthcare leaders. Implementation actually led to a reduction in suicide within our patient population in behavioral health by almost 80%. This model gives clear interventions, helps us teach people what they're supposed to do when they're supposed to do it, and patients the opportunity to understand what kind of experience or care they're going to receive. The idea of zero suicide is really striving for zero defects in the way that we provide care, providing the highest optimal level of care using the most evidence and the best interventions available, and creating a clear systematic care pathway so everybody knows what they're supposed to do and when they're supposed to do it.
The zero suicide approach is consistent with the concept of learning healthcare systems. In this case, it's focused on suicide prevention and the best practices for identification, assessment, intervention, and follow-up care. This research is important because we need to better understand which aspects of zero suicide are associated with risk reduction. And to do this, the study team has developed innovative strategies for measuring fidelity to the zero suicide approach in the electronic health record and using claims data across the healthcare systems.
Suicide is preventable. It's preventable because we can assess for risk. One of the ways that our zero suicide differs is that we look at risks, we stratify them into acute, high, moderate, and low. The key is, how do we modify those risks? So we can modify the severity of depression, we can help people stop drinking, we can help with chronic pain, we can help them deal in psychotherapy with loss. We looked at, well, what type of psychotherapy is most effective? We looked at self-management tools. We looked at weapons. And the last big one was family involvement. So they help us be the eyes and ears. We can teach them how to look for suicide risk and how to intervene. And they can also understand suicide as not a human failing, but as an illness that should be treated like any other. When we first started it, it was a lot of education and training, assessing each patient at every visit for suicide risk. We did a lot of rigorous training in psychotherapies. We also educated and made it easy for people to give self-management tools to patients. And then re-engineering how outpatient therapy and inpatient therapy later on was operationalized so that we had the access and people weren't left with, oh my goodness, this patient's at risk, but nobody can see them for medication or no one can see them for psychotherapy. So part of it was re-engineering how we think of delivering care.
The program then has become an international phenomenon, meaning that it was developed and implemented here at Henry Ford, but then was written into the National Strategy on Suicide Prevention for the United States. After that, the federal government picked up zero suicide, started pushing it out across the United States, and an international movement spawned. Zero suicide has now been implemented in over 20 countries around the world.
So in Nepal, for example, at the start of the pandemic, they had locked down the country and they actually saw a 40% increase in their suicide rate over a 3-month period. We brought a team to Nepal last year in October, including Dr. Brian Amadani, and we presented the Zero Suicide Program to multiple stakeholders in Nepal, including the Ministry of Health, the Ethics Committee, researchers, practitioners, even within schools, and the reception was incredibly well received. Our goal is really to expand the work to other lower income countries over the next few years. Really, through this program, what we're excited about is what types of iterations can we develop after our work in Nepal, after our work in some of these other lower income countries, to improve upon the program even further and possibly bring those ideas back to Detroit and improve our program here as well.
Our goal is to really reach out, to push this work out and adapt it to cultures and communities all over the world. We believe that if we can work hard and partner with people all over the world, we can really have a major international impact in saving people's lives.
We have an international movement to upend the idea in healthcare that suicides are inevitable. The work of Henry Ford has set forth this drive, this relentless pursuit of perfection around supporting people in pain. We can achieve zero suicide in an ultimate world the same way we pursue zero falls, zero accidents, zero cancer deaths, and that ultimately no one should die alone and in despair.
The idea of zero was thought to be outlandish. But if the answer is not zero as a goal, what is it?
After 6 years of work, we found that implementing zero suicide led to a reduction in suicide attempts across all of the intervention sites, meaning that we now had more evidence to support the fact that this model actually works to save people's lives. So it's really what we'd been searching for. We want to use these findings, which are foundational. They're landmark results that can support the implementation of this program broadly and allow us to really save people's lives in communities all over the place. People are right in front of us in our healthcare systems before they're attempting or dying by suicide, meaning that we have an opportunity to do something about it. And that's what this zero suicide work is all about, is that we have to take that opportunity to do these evidence-based processes, to implement these care pathways so that we can actually save people's lives.